We know adverse childhood experiences, or ACEs, have negative impact on adult health, and an ACEs score greater than or equal to 4 has been correlated with a host of negative outcomes. These include decreased resilience, poor self-esteem, increased risk of chronic diseases, intimate partner violence, and substance use disorders. Community health workers, or CHWs, have been positioned in our pediatric emergency department in order to screen patients and help bridge the gap in needs-based resources, ultimately enabling a holistic treatment of pediatric patients based on the parent or caregiver's physical and social health profile. This presentation is essentially a descriptive component of a prospective cohort study of pediatric patients aged less than 19 years old and their parents or caregivers who completed a 10-question ACEs survey upon their visit to the pediatric emergency department. CHWs matched resources and interventions based upon these scores. Cases with ACEs scores greater than or equal to 4, which is really the cut point for a high-risk subject, were assigned intensive support, including care coordinators, and a referral to a clinical child psychologist. Social and demographic variables that influenced high-risk ACEs scores would then be evaluated in addition to resource utilization. A total of 2,932 parents and caregivers were screened. Roughly 9% had high-risk ACEs scores. CHWs provided about 15.3% of subjects intensive support and 12.9% child psychologist referrals. A list of resources that the CHWs provided will be demonstrated on the figure in the next slide. An 8% decrease in the odds of a high-risk ACEs score was noted for each 1-year increase in the age of parents or caregivers. The adjusted odds ratio was 0.92. So that means the younger the parent or caregiver was, the more likely they were to be high risk for ACEs. This figure demonstrates a list of CHW interventions. We see on the left intensive patient support, and on the right comprehensive patient support. Intensive patient support was provided to parents and caregivers with high-risk ACEs scores. That included copay assistance and medication discounts, a home visit within 24 to 72 hours of discharge, a follow-up to verify appointment attendance, assignment of a care coordinator, and paperwork completion for Medicaid, income support, and SNAP, in addition to other governmental programs. Now, the CHW didn't complete the paperwork for the parent, but actually sat there and ensured that it was done. On the right side, we see comprehensive patient support, including paperwork instructions for application for government benefits, a list of new PCPs accepting new patients, health education materials, child developmental stages information, and additionally information on toxic stress and ACEs itself. In conclusion, a small but significant proportion of parents and caregivers had high-risk ACEs scores. CHWs provided a proportional intensive support and child psychologist referrals, so we had identified 9% were high risk, about 13% had received child psychologist referrals. Younger parents and caregivers had increased chances of high-risk ACEs scores. And finally, in the future, additional analytics should evaluate the cost effectiveness of this program in preventing non-accidental trauma. Thanks for listening to the presentation today. Feel free to contact me if you have any questions.